My name is Ivan Ramos. I am one of the consultants in pain medicine at the Royal Berkshire Hospital in Reading. Next slide, please. First of all, in order for me to be talking to you today as an expert in pain medicine, I'd like to introduce who I am and what my credentials should be in order to be able to put myself in this position. I am a trained consultant in pain medicine. I did my primary degree in medicine in Barcelona, finishing in 1997. I came into the United Kingdom in January 97. And in February of the same year, I started my specialist training, initially in surgery in the Oxford Deanery, and later on in anesthetics with an interest in pain medicine in Bristol and London, the Northwestern rotation, later called Imperial, finishing my training in 2007. And since that point, I have been a substantive consultant at the Royal Berkshire Hospital in Reading, with my job starting in August 2007, initially on a shared clinical practice in pain medicine and anesthesia, and since 2012, primarily dealing with chronic pain with no involvement in anesthesia. Since 2017, I have also added to my clinical practice some practice in Medicolegal, dealing with both personal injury and clinical negligence. Currently, I accept approximately 100 new instructions per year. And whilst the majority of them, perhaps about 70%, relate to claimant cases, I do also get involved with defendant cases in approximately 30% of my instructions. The current workload that I have in clinical practice involves approximately 1,600 clinical appointments in outpatients per year, with somewhere around 700 interventional procedures per year, in addition to the medico-legal practice that I carry on a day-to-day basis. Next slide, please. So, first of all, I'm sure that you're all familiar with what pain means in your daily practice defending cases. Pain, there's a strict definition by the WHO, but what pain really is a physical sensation that is accompanied by functional restriction, and the combination of those physical and functional limitations lead to some losses. Those losses are physical, social, financial, economical, structural support, family support, network, friendships, at all levels. And eventually the combination of all those elements will lead to physical and psychological suffering. Next slide, please. However, there are some reservations that we need to incorporate into that sort of definition of what pain is, which is primarily the fact that only a small proportion of people who have a certain condition will develop pain. That applies to all conditions that can possibly evolve into becoming painful, including osteoarthritis, degenerative disease of any joint in the body, any neurological deteriorating condition, abdominal problems. Whilst potentially they all can give pain, it would only be a small proportion of those patients that develop pain as a symptom. For instance, in back pain, we know that degenerative changes within the spine are normal. they are in fact considered a fact of life rather than a proof of disease. And that's based on long series of studies with MRI scanning done from the early 80s, looking into populations with different levels of activity, ranging from very sedentary to extremely sporty, even at a competitive level. And the conclusion appears to be that degenerative changes observed in radiological investigations are a normal part of being alive. And it is only a very small proportion that develop pain, and an even smaller proportion of those will develop disabling level of pain that affects their functioning. And to this extent, it is considered approximately 30% of patients who come to a spinal or a pain clinic, their magnetic resonance findings and the clinical findings don't match. And that explains why so often the treatments that we would institute fail to provide the relief that is intended. Next slide, please. The other consideration to bear in mind is that, as it can be read from what I've just said, pain can neither be objectively measured nor independently verified. And therefore, one of the main difficulties that we rely on when assessing pain is the fact that for the assessment, we rely solely upon the honesty of the person who reports the pain. And not only the pain, the symptom of pain itself, the physical sensation, but also the effect that this physical sensation is having upon their daily life with regards to the restrictions, to the disability that they claim that they have. Next slide, please. And that can be explained to be at a different levels. But before we go into those reasons, just as a broad generality, how do we classify pain? There has been over the years a shift, a change into classifying painful conditions to try and move away from that dichotomy that you often may have come across in your legal practice. That dichotomy where pain sometimes has been classified as organic as opposed to perhaps non-organic. Those difficulties to explain certain conditions that are difficult to believe that they can cause pain, let alone the difficulties, the disabilities claimed. Therefore, in the latest edition of the World Health Organization manuals, the DSM-5 and the ICD-11, pain has been classified in primary and secondary. Primary pain is chronic, and the mechanism that is behind that is thought to be what has come to be known as a nociplastic phenomenon. Nociplastic phenomenon basically is an evolution of the pain gauge theory from the 1960s, 1970s, involved with the concept, the Engel idea of the mid-1970s of plasticity of the nerve system, whereby we moved from believing that the nerve system is a rigid hardware structure and more of a fluid sort of connection of different neurons, whereby according to the need and according to the demand, new connections can be formed and connections that are redundant can be removed. That unfortunately leads to some maladaptive expressions of nerve signal, some of which can be painful. And from a clinical perspective, nociplastic pain is not really a diagnosis. So we tend to define those type of primary pain as hyperalgesia, central hyperalgesia, peripheral hyperalgesia. And conditions that would follow this primary type of pain would be the widespread painful conditions such as fibromyalgia that you may have heard. So effectively, chronic primary pain is a pain that is present because of no other reason. There is no other explanation. Pain is the symptom, but is also perhaps the disease. Contrary to primary pain, we've got secondary pain, which are the situations where pain is a symptom of something else. In this context, secondary pain can be either acute or chronic, according to the duration. The mechanism of pain, the etiology, is more perhaps easily understood and is classified typically into nociceptive or neuropathic. Nociceptive pain is the pain that comes from the musculoskeletal system. And nociceptive pain is the pain that follows wear and tear, degenerative process, sprained ankle, if you cut yourself with a knife or with paper at work, if you prick your fingers with a rose bush in the garden, things like that. Neuropathic pain is the pain that is felt to be the result sometimes of nerve damage, nerve trauma, but very often simply the result of nerve malfunction. And a specific type of secondary pain that is perhaps more relevant to the medico-legal setting, to the litigation context, is what we call post-traumatic chronic pain, whereby normally we observe a mixture of nociceptive, musculoskeletal, and neuropathic features in an area closely related to a part of the body where there has previously been an injury, and that injury may well be what would be considered to be the index event, the index accident, the index injury, the index trauma, the index surgery, and then we ought to evaluate whether it could all be related to, the symptoms could be related to that index event. Next slide, please. So nociceptive pain, as I explained before, is typically musculoskeletal pain or visceral pain, and basically is the pain from the skeleton, bones, muscles, or from the internal organs of the chest cavity or the abdominal cavity. Next slide, please. Neuropathic pain, the pain that I described earlier being secondary to either nerve damage or nerve malfunction, is typically felt as a burning, stabbing, sharp, electricity, stingy, prickly, pins and needles, odd sensations, like a sunburn, like a toothache, type of feeling in different parts of the body. It typically is localized to an area where there has been an injury and would be expected to follow the pathway of a specific nerve. Next slide, please. The pain perhaps more difficult to understand is the nociplastic pain, the pain that I explained to be the result of a maladaptive change of the nerve system. That pain is often widespread, and it has been classified over the years with different terms. Not uncommonly, it falls within the remits of what particularly psychiatrists would refer to as medically unexplained pain symptoms. And that simply means that there is no objective investigation that will give an indication as to why the pain is present. It is also typically described in the medical legal context as non-organic, out of proportion. And going back to the potential psychiatric terminology, it is not uncommon to see psychiatric reports and even some pain expert reports where references to a somatoform pain disorder have been made. The important thing to understand is that from the perspective of a psychiatrist, pain that is not explainable on a physiological basis, on a mechanism of injury or a specific pathology, because of the psychological effect that pain on a long-term basis has, and because of the way that we assess that psychological effect, we can see that there have been changes in behavior. Psychiatrists often referred to that combination of unexplained pain with behavioral changes as a somatoform pain disorder. From a pain medicine perspective, however, we classify what is exactly the same entity as chronic primary pain. And the explanation from a physiological pathophysiology perspective would be a nociplastic hypersensitivity phenomenon. But effectively, what a psychiatrist calls a somatoform pain disorder is the same entity that we, in a pain medicine context, would refer to as chronic primary pain. Next slide. And in order to understand why this evolves to being called differently by different specialists, we need to understand the multidimensional implications of living in pain. Pain, as I explained before, is a physical sensation that is not in the head, it's in the body. Pain is where those who suffer from it feel that it is. The only correlation with the pain being in the head is that it is the sensory cortex in the brain that will give us the awareness of a part of the body hurting. But pain, despite being a physical sensation in the body, has psychological implications. Psychological implications because of the beliefs that people have with regards to the reason why they are ill, because of the emotions that people feel when they are in pain. When somebody is in pain from a degenerative process, particularly when that happens from an early age, which sadly is not uncommon, people feel all sorts of distressful emotions. Difficulty to understand why them, difficulty to accept the limitations that they have, difficulty to accept that they may be less able to commit to carrying things out that other people around them, much older perhaps, are able to do without any obvious problem. Difficulty to understand that they have to give up things at the end of the day, to postpone them to the following day because they cannot carry the entire workload that they set themselves to do. Perhaps there are also some difficulties with accepting themselves as who they are, with seeing themselves as failing others around, seeing themselves unable to do what others expect that they would be able to do, or what they believe that others expect that they will be able to do. And as a result, there's a loss of self-confidence that will eventually lead to frustration, perhaps anxiety when facing certain situations that they know will be painful or can potentially be painful. When you have situations whereby the pain deteriorates and improves, there can be changes in behavior that mean that whilst typically people who suffer from pain would fall into those who curl themselves up in a ball and feel very sorry for themselves and expect everybody around to feel sorry for themselves, or on the opposite end of the spectrum, there are those people who, regardless of whatever it is, they will fight it and continue to hit a wall with increasing level of symptoms every time that they overdo it. And eventually, as a result of repeated periods of increasing level of symptoms with increasing difficulties, increasing disabilities, resulting from overdoing, both those types of extreme approaches will move more towards apathy, towards depression, towards lack of stamina to do things, towards lack of stimulation, lack of will to do things. And that is where the link between the physical symptom of pain and the psychological, psychiatric anxiety, depression, low mood, affective disorder starts to creep in. But as can be seen from the psychological effects, there are also a lot of social changes. Somebody who might be employed in a reasonable position with a reasonable income, having a reasonable quality of living standard, may lose that, may lose the income, may lose the social support, may lose friends, breakdown in families, tense relationships with the people that are living within the same household as a result of the relentless nature of a nagging pain that stops you being able to do what you want to do. So eventually the social structure can crumble, sometimes more significantly, sometimes less significantly. And all that is determined basically with a combination of who we are and what we have learned. We know that there is a genetic predisposition to developing certain conditions, but we know from studies looking into how twins evolve that some may present with different symptoms in the face of the same diagnosis, and that relates primarily to pain. Some twins, because they have the same genetic material in their genetic imprint, will develop certain conditions. And the symptoms, particularly of pain, can be more overwhelming in one than on the other. And that is due to the interaction between the social and the psychological elements, regardless of the fact that they've got the same genetic predisposition. We learn our behavior in the face of adversity, and pain could be considered to be an adversity based on our experiences from early life, and also based on the experiences that we have seen others around us dealing with similar situations. If we are brought up in an environment where disputes are resolved by slamming doors, shouting and breaking the crockery, we will learn to see that that is an acceptable way of dealing with problems. Whilst on the contrary, if we are brought up in an environment where disagreements are resolved by sitting at a table and bringing the issues up to try and clarify them, we will understand that a more diplomatic approach to sorting differences is perhaps more positive. Next slide, please. So a lot of those elements that change our reaction to pain and determine how or why only a proportion of patients in the face of the same injury can have symptoms of pain and some patients don't, evolve in the neurobiology of us as individuals. There can be mutations in the genetic imprint that are inherited. It's not uncommon to see that there are traits in families whereby a trivial injury, sprained ankle, can linger for months, sometimes even years, being symptomatic. There are traits that we observe when we review medical records where an injury that should have healed in a few days or even a few weeks has led to multiple consultations with general practitioners, multiple referrals to physiotherapy, multiple referrals to specialists, and eventually resolution of the symptoms, sometimes spontaneously, after many months, sometimes even years. One of the elements that appears to be linked to these genetic mutations is what typically is called channelopathies. Primarily those that relate to sodium and calcium channels, whereby there is an abnormal transmission of sodium and calcium, with those being the two chemicals that are involved with nerve transmission throughout the entire length of the nerve cell, and trigger the release of neurotransmitters in order to activate transmission upwards towards the sensory part of the brain. So people who have an inherited mutation in the expression of those sodium channels can typically have increased levels of experience of pain to the same stimulation that for other people would be painful, and occasionally it's exactly the opposite. They are denied the experience of feeling pain. But in addition to that, there can be non-genetic, non-inherited modifications which effectively relate to the fact that despite the fact that a gene is expressed in exactly the way that it's supposed to be expressed in order to achieve the proper working ability, there has been another element that has rendered that gene malfunctional. So the protein that comes out of the gene structurally is normal, but the function is abnormal. And that can be present in situations where there has been exposure to chemicals, where there has been exposure to radiation. And even though there has not been a genetic mutation in the DNA, the function of the proteins that are manufactured when that DNA is expressed leads to abnormal function of the nerve. And that sometimes can involve increased sensation to touch, increased feeling, increased level of pain. But that basically relates to the physical nature elements. How about nurture? As I expressed earlier, our experiences change, determine how we react to pain, how we react to adversity. But also there are some physical stimulations that can also determine our reaction in the face of pain and adversity. It's not that long ago, when I was training doing my clinical training in pain medicine in the mid-2000s, I did an attachment at a pediatric unit in London and Chelsea and Westminster Hospital, and we were at that stage starting to move away from the deeply ingrained old concept that children don't feel pain. And at that time, it was started to be accepted that we ought to give painkillers to children. We were one of the very first units in the country that started to give Ormorph, liquid morphine, to children following surgery. And I'm talking about big abdominal surgery and maxillofacial reconstructions that involve a very large degree of tissue dissection and therefore will be painful. And because they were babies, the feeling was that if they were crying because they were on their own, because they were hungry, because they were missing their parents, because they were in an unfamiliar environment. But it was difficult to accept that that was because of pain. And those exposures to pain at a very young age have led to fears, have led to anxieties around medical treatments, have led to anxiety and phobias of needles, going to see the GP, white coat syndromes, fear of having surgery, fear of having a general anesthetic, and learned pain behaviors that lead to avoidant attitudes with regards to doing activity that are known can cause pain. So very early experiences, both physical and also psychological, that we have felt and witnessed can affect our response to pain. Then there are adaptations that we can do to our own clinical brain pathways with regards to how we modify their working. Addictive behaviors. Addictive behaviors work on the reward motivation pathways, dopamine channels, basically. And they basically rely upon providing a pleasant stimulation, which we seek. So if we find a substance that gives us a sensation that we find pleasant and we crave, we learn the behavior of seeking that substance. So we have changed a behavior that we were programmed to, and that can also lead to bad behaviors, potentially pain. Descending neuromodulation relates to manipulations that we can have in the pathways that control the response to pain by the use of tense machine, massage, acupuncture that will release endorphins through creating fasciculation of nerve fibers, and they can close down the ascending pathways of the periphery up to the brain, so therefore reducing pain, or they can close down or manipulate downwards the descending pathways that trigger a response on the musculoskeletal system in response to a sensation of pain. Equally, this could be seen to be the mechanism by which cognitive behavioral therapy, psychological rehabilitation techniques, meditation, mindfulness works, whereby it is known that Buddhist monks that are masters at meditation feel more pain than people who don't meditate. And we know that through functional MRI scanning that shows us sensory cortex in Buddhist monks gets stimulated to a higher degree when inflicted with peripheral pain. However, they have learned to switch off the pathways that will link a motor response down to the peripheral nerve system, and therefore they can modulate the reaction that they have in the face of pain. So even though they feel pain, they don't act on it. So with time, they learn to ignore it. And that is why cognitive behavioral therapists that try to promote meditation and mindfulness can be used for the treatment of pain. The adolescent brain, hormonal changes, hormonal stimulation on the brain, they set trends, they set stimulations, they set behaviors. And then, of course, we all know that there are certain personalities, certain anxious types out there that are perhaps more prone, have a propensity to developing chronic painful conditions or any chronic ailment to the same extent. Next slide, please. So with all that in mind, some people have set themselves to look into what a vulnerability to chronic pain may be. The problem with looking into this is that with time, more and more elements have been added to these vulnerabilities. And that effectively negates the existence of a real vulnerability, because for something to be considered a vulnerability, it has to be different from what is considered to be normal. Therefore, the larger the categories that fall within the vulnerability spectrum, the lower the spectrum of normality. And to a degree, there's an argument to limit what we consider vulnerabilities in that regard. But typically, we considered that vulnerabilities to chronic pain come from a physical and from a psychological perspective. From a physical perspective, exposure to a long history of chronic pain is known to be one of the elements that determines predisposition to developing chronic pain when faced with trauma, however small that trauma might be. And typically, studies show that pelvic pain and back pain are the most predominant in that sense. But also we know that personal or witness history of psychiatric illness, primarily anxiety and depression, can also predispose to developing chronic pain. Recreational use of drugs can equally, whether it is personal or witness in an environment that some patients, some claimants may have grown up, can also be predisposing elements to developing chronic pain. From a socioeconomic background, difficulty in the domestic situation, troubled households, having situations where there are behavioural challenges at home, either seeing behavioural challenges in our parents when we're little, or living in a situation where as adults, our own children have behavioural problems, can be stressful, can make somebody more prone to developing chronic pain. Coming from a poor socioeconomic background, low-income households, working in unsatisfying, low-skilled, low-income, low-demand types of jobs, having problems, tensions at work with difficult situations with low pay in exchange of a high demand, is more likely to predispose somebody to developing a disabling painful condition when faced with trauma. Isolation, social isolation, psychological isolation, having a very small network of not very supportive relative or friends. All those are elements that from a socioeconomic perspective can predispose an individual to developing chronic pain when faced with an injury. Next slide, please. From a childhood perspective, there is this concept of the adverse childhood experiences that basically look into what elements a child has been exposed to that can mean that they are more likely to react in an unhelpful way in the face of adversity, either physical or psychological. So the common elements that are widely accepted to be part of this ACE, average childhood experiences spectrum, is living in a household where domestic violence was common, living in a household where there has been a breakdown in relationships, divorce, marital disagreements, domestic violence, being exposed to seeing domestic abuse with regards to parental fights, perhaps even physical. Living in a household where children have been submitted to neglect, physical or emotional, or abuse of any type, physical, sexual or emotional. Having personal history of being exposed to an environment where others have suffered history of psychiatric illness. And finally, living in a household where parents or siblings have criminal records, have been in prison. All those are elements that can potentially be seen to alter the behavior in response to adversity from a very early age. Next slide, please. So, on the contrary, we've got several elements that are known to provide resilience to developing chronic pain. So living in a safe, stable and nurturing family and community environment with good social support, with reasonable quality of life, having proper breaks from work, relaxation, having positive friendship groups, being in a supportive environment that allows you to develop as a child your positive trends, who allows you to perform positively at school. All those are good protective elements that improve the psychological well-being, improve the self-confidence to be able to carry out tasks, improve the motivation to carry out tasks, and therefore they reduce the psychological components of living in pain. So even if those people in adulthood develop chronic pain, the effect, the response will be very different from those children who as adults develop chronic pain, having had a very different childhood background. Equally, being exposed to positive role models is important, with a view to setting goals for the future and knowing how to act in different situations. So overall, it's appropriate provision of the care that a child should have when they are growing up, developing and learning from those around them. Next slide, please. So when looking into the interaction between those elements that give a vulnerability to developing chronic pain, physical or psychological vulnerability, that is, against those elements that appear to protect against developing chronic pain, vulnerability and resilience, both of them account for the expression that we see of pain. Pain, the patient, the claimant feels it. We, as individuals, as third parties, see the behavior, see how they move, see what they do and what they don't. That's the physical outcome. So they both, resilience and vulnerability elements, have an effect in the physical outcomes, but the effect is similar. There is no increase or no higher detrimental effect from vulnerability as there is beneficial from resilience. However, when we look at the mental health related outcomes, which is effectively the gray cloud that you have in your head when you are not feeling well, which is effectively the feeling of helplessness that comes from feeling pain and being in a situation where you see yourself as unable to do things that you are expected to do. So from the perspective of the mental health outcomes that eventually lead to anxiety and depression, the resilience elements do contribute highly compared to the vulnerability elements. So the protective effect of a good background is higher than the vulnerable effect of a poor background. Next slide, please. And that is basically the rationale behind offering rehabilitative strategies to dealing with pain. So because of the correlation between pain and psychological distress, we know that whilst we cannot change the physical sensation of pain, because injections hardly ever work, and when they do, they work for a short time, they're not prolonged, long-lasting treatments. Medication doesn't work for long-term pain. There's no one painkiller that is guaranteed that will help for a long-term pain. So acting upon the physical sensation of pain is extremely difficult, borderline impossible to do. So the only thing that we can treat with a good, reasonable chance of succeeding is we can address the behavior in response to pain. We can provide coping strategies to increase the psychological resilience, to make those patients, those claimants who suffer pain, to be able to carry on doing things regardless of the pain, to help them learn to ignore the sensation and to help them learn to ignore that they can stop thinking that pain equals damage. The pain score as such, first of all, is not validated on a chronic pain setting because patients, claimants lose the landmark, lose the goalpost, and what is a pain of 10 out of 10 10 years ago, what is a pain of 10 out of 10 today may have been considered a pain of 5 out of 10 years ago, or vice versa. So the pain scores are actually not validated tools in these settings. The difficulty with implementing rehabilitation techniques is that by and large, the foundations of rehabilitative strategies rely upon pacing strategies, and implementing pacing strategies more so on a productive daily life, let's say in a production chain in a factory, is extremely difficult. It requires a very cooperative and understanding employer, which can sometimes be difficult to find. Next slide, please. So, in the context of litigation, the problem that we face is that pain is a symptom that acts as a reminder of the injury. But so does the process of litigation. If earlier I said that patients who have chronic pain in the context of degenerative disease, in the context of surgery, that acts as a reminder of the injury, in the context of litigation, the pain acts as a reminder of whatever accident they were involved in. And that creates anger, creates a sense of injustice. And when you combine the reminder of an injury, the stresses with the process of litigation, the sense of injustice, with the fact that in life, if there are two disciplines that everybody is knowledgeable in, those are law and medicine. We all have a neighbor that is very likely to give us the advice that surely you must be entitled to some compensation because of what has happened to you. That only increases the sense of injustice, because then we build compensation into it. And it leads to a situation where, with time, compensation and revenge gets blurred. A lot of claimants see that compensation is to give them something back because they have lost something. But they fail to see that what they would be getting back is to put them at the level where they would be had the accident not happened. So very often I hear, when I ask claimants about how something is affecting them, how the symptoms are affecting them on the daily living, I very often hear about, if only they knew what they've done to me. They don't have a clue what they've done to me. It's only fair that they get it back. I frequently hear expressions like that. That, in my mind, goes into the remits of revenge, regardless of how high your sense of injustice might be. That sometimes is fed into because of poor understanding of illness. I have seen many claimants that, because they've been told that they may have difficulties to do the very physical job they've been doing, from that they understand that they're being told not to work. From that they understand that they're being told that if they don't go on a wheelchair in a year's time, in 2 years' time, they'll be unable to stand. If they, there are a lot of misunderstandings in the concept of illness and how the illness is supposed to affect, or what is expected to affect somebody, or how it's supposed to affect somebody. But also the other element is that in the context of litigation, the value of the claim is related to the degree of damage, to the degree of disability. So it is not uncommon that claimants come to a medical legal assessment trying to report very vividly how the symptoms are affecting them. So from a medical legal perspective, we have to analyze all those elements very carefully when we evaluate the history that has been related to us. Next slide, please. And the important element of that is to consider that despite the vulnerabilities, despite having personality, somatoform disorder, whichever way we want to call it, despite being furious, despite being angry, despite sense of injustice, the claim must still be genuine. And it is a difficult task that we have to do to try and eliminate those elements, to try and come up with an approximation as to what could be explained to be genuinely attributable to an injury and what can't. Next slide, please. So, since we have access to the medical records, our duty is to review them with a view to outlining vulnerabilities that may have been present in the past, those that I have explained earlier, to observe patterns of behavior historically, or patterns of behavior following the injury. We observe, I've seen many claimants that they have ongoing symptoms. They claim that an accident has made their ongoing symptoms worse, but actually when you look at the medical records, the pattern of behavior of those symptoms is perhaps not very different from the pattern of behavior of those very symptoms before the given accident. We have to look at the ongoing report, what symptoms they are reporting to the GP, to the specialists on a daily basis or on a frequent basis. I've seen claimants that report pain in the lower limbs when actually on the day of the injury, they only report pain in the neck, and explaining pain in the hips and knees 6, 8, 10 months after a car crash is actually quite difficult to do. My experience of medical legal cases is that the issue of liability is rarely disputed. Sometimes it is, but frequently it's not. So it goes down to the quantum, to the value, to assessing the level of disability, the level of injury, and the effects that this is having. Effectively, it goes down to veracity. And in order to assess veracity, we observe the behavior of the claimants when they come in. We observe the way they walk, the way they sit, the way they stand, the way they move, the way they react to what they say, the way they react to being examined, the way how cooperative they are to willingly allow us to examine them. So we assess all those things. We assess the mechanism of injury. We assess the symptoms of the report. We try to explain if that injury could cause those symptoms. We look at the symptoms that they are reporting. We look at the symptoms that they are, or the disability that they are reporting, and we try and see if we can match those symptoms. And therefore, bearing in mind the behavior and the injury together with the symptoms described, we try to make an assessment of veracity to try and help the court and yourselves to ascertain whether the claim can be defended, whether the claim can be repelled, can be rebated, can be argued. And if we get to the point of recommending treatments, resilience is key to the psychological experience of chronic pain, and therefore, and following NICE recommendation, psychological support, rehabilitation, treatment would be very often the treatment recommended, or rather, very rarely not the treatment of choice.